Understood. This I have done like this.
Okay.
Shall we start, sir?
Sir, you have not done this. I think you are on mute.
Madam, you can start.
You can start, madam. You can start. Yeah.
Good afternoon, all. We welcome from Department of Psychiatry, Rajarajeshwari Medical College for IPS-KC postgraduate student case conference. I welcome Dr. Gururaj, sir, Professor and Head of the Department of East Point Medical College and Research Center. Our postgraduate student final year, who is Dr. Asha, is presenting the case right now. We'll be starting the case presentation.
Good morning, everyone. Good afternoon, everyone. I am Dr. Asha from PG Department of Psychiatry, Rajarajeshwari Medical College. So I'll be starting with the case of presenting case today of Miss A, who is of 19-year-old from Kengeri. She is doing bachelor's degree student, and she is unmarried, Hindu, belongs to middle class, and she is Telugu speaking. Informant is self and parents, adequate and reliable information. Chief complaints, hearing of voices, according to the patient, hearing voices not heard by others, choking and twisting sensation inside her throat, touching sensation since 11 months, decreased sleep since 10 months. According to the parents, withdrawn behavior since 6 months, self-muttering, smiling and looking angry when alone since 6 months. History of presenting illness, onset and course. It is a gradual, continuous and deteriorating. Predisposing factors are nil. Precipitating factors, as she is stressed about the studies. Perpetuating poor insight. Physical factors are none. Patient was apparently all right 11 months ago when she began hearing 2 to 3 unknown male voices whispering in both ears without being able to understand the content. She could hear the voices when she is fully awake, alert, and also reports that these voices are coming from outside and were initially present when she was alone. Over time, she began hearing the voices even in the presence of others. Initially, the voices occurred for 5 to 10 minutes, 1 to 2 times per day, during which she felt frightened and searched for the source of the voices. Over the next 2 to 3 weeks, the frequency gradually increased to 20 to 30 episodes per day, with the voices becoming clearer. The voices addressed her directly and also conversed among themselves predominantly in English and Kannada and occasionally in Telugu. According to the patient, these voices belong to some gangsters aged around 25 to 30 years, and their job is to kill young people. These voices follow the instruction of main boss, whose voice is not heard, but the patient came to know about him when other 3 voices were talking. After 2 to 3 months, patient claimed that these people installed some super AI cameras in 5 different parts of brain, which are in the shape of an ant. She came to know about the camera from voices discussing. On asking patient about the possibility of installing camera, then she told through AI technology and with the help of IRS, they can install these tiny humanoid AI cameras. She told she will elaborate later since it is secret as those people are observing. Over the past 2 months, she reports of hearing voices most of the time. Talk to her directly, referring her as you. For example, you are studying well, you stop reading now, or threatening her like we will kill you. Voices discuss among themselves about her, referring her as she. For example, look, she is studying now. She is not listening to us, or commenting her day-to-day activities. Like these voices continuously comments on her actions, such as she's opening her book now, she's writing now, she's getting up and she's looking around, describing her activities as they occur. At times, they influence her actions against her will. For example, making her open YouTube and watch videos suddenly, though she does not want to, interrupting her studies or compelling her to stop tasks despite her intention to continue. Patient believes that her thoughts are no longer private and are being transmitted to uh, others from brain to an ant camera, from ant camera to them through AR rays. She reports that those gangsters can hear her thoughts as soon as they occur. For example, when she thinks, I should study now, the voices immediately comment, she is thinking about studying uh, we know what you are thinking. Though she uses headphones or earplugs to muffle these voices, as well as to stop her thoughts from being transmitted, it has not been successful. Patient reports a twisting sensation in her throat and neck, which she believes is caused by those people through implanted AI cameras, leading to pain and choking sensation. She believes this is an attempt to kill her by interfering with her breathing. These episodes occur 2 to 3 times per day and have been happening almost daily, and drinks water to get relief. Patient reports that they started touching her inappropriately, which is making her uncomfortable and sometimes pain. She does not want to share the details as she is feeling bad. They also torture her by putting some liquid in the throat through mouth forcefully. Initially, she does not know what it was. She felt only some fluid in the throat for some time. Later came to know it is beer through its taste and smell. She also tells that they are mixing some unknown drug to kill her. As it is causing her damage, she would immediately spit it out and drink water. On asking about the taste, she told it is bitter in taste. Sometimes patient feels something in the throat which is causing her uneasiness. Hence, she drank lot of water to clear the throat and tried to spit out the saliva. Then, few instances, she saw the ant-shaped camera on her hand. She described it as black in color. Later, threw it away in the dustbin, but was again implanted by those people through IRMs. According to patient's parents, they noticed muttering to herself appeared to be in angry conversation when alone in room. Initially, she would explain about few things to her parents. They shouted at her, telling her that she is finding excuses to skip her studies. Later on, she stopped sharing such things. They noticed that she was sitting mostly alone with browsing phone, refusing to attend college. On asking her, she told she had to go to college by bus. At bus stop, she would see some unknown men looking and talking about her. She gets scared and looks at them angrily to scare them, but never confronted them. Hence, stopped going to college by bus, insisted her father to drop her. Sleep of the patient is disturbed since last 10 months. She goes to bed at 9:30 p.m., sleeps within 20 to 30 minutes of going to bed, depending on the voices bother her or not. If she is awake in the middle of the night, she would hear the voices and difficult to sleep again, resulting in tiredness, no daytime napping. Patient has decreased food intake. Though she is hungry, she is not eating food in adequate quantity because of choking sensation, twisting, and uneasiness in the throat. Negative history. No history of head injury, loss of consciousness, abnormal jerky movements of hands and legs, hypertension, type 2 diabetes, thyroid abnormalities. No history of substance use. No history of any other false or abnormal beliefs. Denies history of any thought is being inserted or removed by an external agent. External feelings, drives or imposed by any external agent, abnormal posturing, loss of emotional expression, loss of motivation and goal directed behavior, loss of motivation and goal directed behavior. No history of persistent pervasive sadness, loss of interest, easy fatigability, elevated mood, attempts of self-harm. No history of constant excessive worry, increase in heartbeat, difficulty in breathing, sweating, hot or cold flashes, fear in specific situations. No history of repeated thoughts, acts, images, or impulses. Past history, no history of similar complaints, not a known case of diabetes, hypertension, ischemic heart disease, seizures, or thyroid disorder. This is the family pedigree chart. Coming to family history, patient's family is from Andhra Pradesh. Father is working in Bangalore, hence they are staying at Bangalore for 20 years. Father age is 45 years, BCom graduate, working as supervisor in a private company. Mother age is 42 years, second PUC, homemaker. Parents' marriage is non-consanguineous arranged marriage. Since 20 years, she married since 20 years. She is only child. It is a nuclear family. Due to her illness, there is a misunderstanding between parents and patient. No history of any other medical illness, epilepsy, mental retardation, substance use, psychiatric illness in the family. Current social situations, patient lives with her family. Social supports, primary are parents, secondary teachers and friends, tertiary psychiatrists and doctors. Personal history, birth and early development. Prenatal period is uneventful. Natal delivered by full-term normal delivery with no complications. Postnatal period uneventful. Milestones of development, attained milestones at a appropriate age. Behavior during childhood is normal. Physical illnesses during childhood is none. Schooling history, age of beginning is 4. Type of school she attended LKG to 10th standard in an English medium, passed with first class, and PU also she passed with first class, currently pursuing bachelor degree in commerce with average performance in the school. Currently academic performance is declined due to current illness and is irregular to the college. Attitude towards peers and teachers, she maintains a cordial relationship, enjoyed playing tennis and coco, but currently not actively talking to friends or participating in sports. Nil occupational history, nil substance use. Menstrual history, menarche attained at 12 years. Initial response was apprehensive. Current cycles 4 to 5 days. Moderate flow 28 to 30 days per cycle. Last menstrual period was on 6th of December. Currently hygiene is maintained during cycles. Sexual history, she is heterosexual in orientation. Source of knowledge and practices are not available as the patient did not give any information. Patient is unmarried. Premorbid personality. Uh, when coming to social relations, she's lively and socially engaging, extrovert. Intellectual activities are she loves watching movies. Her mood is cheerful, and her character is described by she is confident and responsible, with nil habits, believes in God. Whenever she is stressed, her reaction is crying and talking to parents. She is energetic, enjoys working and going out with friends. Used to fantasize about becoming a tennis player. Hence, I infer patient has a well-adjusted premorbid personality.
There are no more questions, no questions as of now. Shall we wait for some time for questions to be posted by the audience?
Yes, sir.
Yeah.
Can initiate the moderators or anybody can initiate any discussion or anything, any positive points, anything needs to be clarified. The questions can be posted or questions can be asked.
Asked,
You can
yeah.
unmute. You can unmute and ask the presenter. Can you give a better description of touching sensation? Because one of the chief complaints is touching sensations.
Uh, so actually, according to the patient, the screen is stopped. 1 second.
It is visible.
Oh.
Yeah, but Anil Kumar has a question there as well. That's a very important and a valid question there.
Patient is having touching sensations. She told us she used to have sensations in a mostly in a inappropriate way and inappropriate manner. She told she doesn't want to describe about it as it is. She's feeling bad. That is the reason I couldn't able to elaborate more about it.
And she never thought of like no death wishes, active death wishes, suicidal ideas, secondary to this kind of.
No self-harm. Anything is there, we'll clarify in the next visit.
Okay. Any acting out behaviors secondary to this? So many active psychopathology is there. Any active behaviors since she is a graduate, she would have tried in all possible ways to know why it is happening.
As I mentioned in the HOPI, sir, like for all the like voices she's hearing, she's acting out by putting ear plugs
Yeah.
or mufflers and all to muffle the voices and all, and for the choking sensation and the twisting sensation, she's drinking water, and taste sensation also, she's drinking water and spitting out. So in the way she is acting out. And for when she occasionally when she saw the ant camera, she tried to search about the ant camera through internet, and so most of the through browsing the internet.
There are questions in the chat box, Dr. Suresh. There are two questions from Dr. Kasturi and Dr. Anil Kumar Nagaraj. To Dr. Asha, okay, I mean, is there any childhood adverse experiences like school bullying? Dr. Nagaraj wants to know that.
As of no, sir. When we asked in the interview, there is no childhood or adverse behavior.
I am not able to say any PGs here, but I will ask you one question, Dr. Asha. You presented the case, it's a straightforward diagnostic case. You said the precipitating factor is academic stress in your slides, but you do not talk about it. You just see in your slides, I thought I saw academics was stress was an academic academic stress was something, a precipitating factor. Can you please talk about that?
It's about parents are a little not very strict, but they are very particular about studying and what timings, what she is maintaining, and also how she is studying, what she is studying. So that's why she is very much she is stressed about the studies.
No, but you mentioned in this, for the current onset of the episode, the onset of the illness, you mentioned as precipitating factor. She finished 10th and she finished plus two. Plus two could be stressful as well. That time she had no any episodes of anxiety or phobias or any abnormal behavior during then.
No, sir. That time she didn't have anything. But after finishing the plus two and once she started pursuing the graduate course, then the history of whatever she is giving, the timeline matches like after joining the graduation.
I'm waiting for some more questions from the PGs. I hope there are. Okay. Yeah. Clarification in history is commenting, but can be commentators, is Dr. Kasturi's question to you, Dr. Asha. Some more new messages. Did you mention all the perceptual abnormalities, Dr. Asha, in your presentation?
Yes, sir.
In the negative history as well?
Yes, sir.
Any olfactory you mentioned?
Olfactory, it is there in this is the part of psychopathology, sir. She is having olfactory hallucination.
What smell does she? Where did you present in your? Did you mention about in your presentation? HAPI?
Yes, sir. Yes, sir.
Okay. Sorry, I missed it. Very good in that case. Okay.
Sir, I will share that slide, sir. Sorry.
It doesn't. It's okay. It doesn't matter. If you have mentioned it, it's very well and good.
1 second. Sir, I have mentioned that here it is. After this, I'll clarify it in the MSCs.
Fine. You can. Yeah, I'm sure you'll clarify in your MSc. Okay. Let's wait for some more questions in the chat box. And Dr. Suresh asked question for about depressive, comorbid depressive condition. You said there is no pervasive mood symptoms, but was she not even sad for it? Because there are inappropriate touch, somebody's commenting about her all the time. Didn't she feel sad or angry or upset? Because you said she shares with her mother if she had a stress in her child, pre-morbidly you said, if she has stress, she would talk to her parents about it. In this case, she did not feel upset even once.
Sir, at very little, at times, and that too very little, she is sad, sir. But it is not persistent and pervasive. It is more of other, like she's scared, anxious, and fears. More than the upset or more than sadness, her way of when she mentioned she is more worried, sad, worried and fearful.
History of substance abuse, I think she has mentioned that, Dr. Kasturi ma'am. She did not say she had any substance use.
Sir, I have mentioned.
Yeah, you mentioned that she has no substance use, doctor. Yes, it was very clear in your history. I'm just trying to reply to the questions as well from your end.
Sorry, sir. Actually, I'm not able to see the chat box here. If I'm opening the chat box, sir.
Well, I will read it for you. I think Dr. Lakshmi's question is, what is the sensation in her throat?
Sir, it is like a twisting and twisting sensation, sir, in the throat.
Swallowing issues, I think it's also been addressed, right? I think she can continue, Dr. Suresh. I think there are no more questions. I think let's go forward.
Yes, sir.
Unless Dr. Vidhyavathi has something to say and something to add.
Sir, to add for the twisting, actually the patient's mother tongue is Telugu when she told me. So then can I mention the word what she used for the testing? So she told that tipputundi, that's what they tell me. That's what she used.
Tippatundi, what does it mean? I mean, we are not Telegaites, we are Kannadigas.
So
It is
that
turning, is it? It is. Are you a
twisting.
Telugaite?
Yes, sir.
Okay, doesn't matter. So it is okay. Fine, carry on because you had no difficulty in establishing rapport, is what I understand from your presentation as well. Right? You did not mention about difficulty in establishing rapport there. Carry on, doctor. Carry on. Yeah.
So coming to mental status examination, general behavior. Sir, 1 second. Patient entered the room when called and sat on the chair as asked, but with lot of hesitation and did not greet back. Level of sensorium is normal. Dressing and grooming is kept. Psychomotor activity is increased. Eye-to-eye contact is initiated but not maintained. Patient get scanning around the room. Rapport couldn't be established. Uh, Posture sat on the edge of the chair, wanting to leave. Facial expression disinterested. Hallucinatory behaviors are present. Made posters of listening as if someone is talking to her. She did not answer when asked about the same. Tics or mannerism and other abnormal movements and any catatonic phenomena are absent. This is the speech sample given by the patient. She is interested in tennis, so I asked her to talk about tennis. Tennis is a sport. In tennis, two types of courts. One is tennis is lawn tennis court and clay tennis. It is good for our health. Tennis is famous game sports in the world. Sania is the tennis player. Now she become the famous tennis player in the world. She got a gold medal. She also silver medal and awards from Prime Minister. So from the speech sample, I infer that it is a non-spontaneous speech, relevance and it is relevant and coherent. Reaction time is increased. Absent pressure of speech, poverty of speech is present. Intensity is abnormally soft, low in voice, heard with difficulty. Ease of speech, she is hesitant, characterized by frequent pauses and breaks. Tone, volume, tempo is decreased. Prosody of speech is maintained. Mood is subjectively fearful most of the time, and at times she is worried, objectively anxious, constricted range, reactivity is present, mood congruent to thought, appropriateness is present, able communicability is absent, lability is absent. Thought, stream, light of ideas is none. Retardation of thinking is present. Circumstantiality, tangentiality, perseveration, thought blocking is not present. No formal thought disorder. Obsessions and compulsions are not present. Thought alienation phenomena, thought broadcast. Patient reports her thoughts are being transmitted to the people whose voices she has been hearing as soon as she thinks simultaneously. This transmission is from brain to AI camera through IRS and through it to those men. Hence, she avoids talking or sharing anything. Patient denies thought insertion and thought withdrawal. Content of the thought, multiple delusions. Delusions of a delusion of reference. A patient has believed that people around her, mostly strangers, are looking and talking bad about her and making fun of her. It is elaborated, systematized, secondary to auditory hallucinations, mood congruent, and acting out by avoiding people and looking angry at them to scare them, uh, associated with feeling angry and scared. In delusion of persecution, a patient has believed that some unknown people are trying to kill her by forming gangs, pouring beer and drugs in her mouth. It is secondary to hallucination, systematized, elaborated, mood congruent, associated with feeling of fear, frustration, and sadness. The patient acted on it by withdrawing from her social circles and spending more time at home. In maid phenomena, act and volition, patient has believed that previously mentioned people are controlling her actions and making her fail at things. She tries to do with focus. It is secondary and systematized, elaborated, mood congruent, and associated with the feeling of anger and frustration. Patient acts on it by silently cursing in her mind or muttering curses at the people whom she believes that they are behind her every time she messes up with something. Passivity phenomena, patient experiences twisting and choking sensation in her throat as well as fatigue and sexual sensations when she is alone. She believes that these are done by the gangsters. It is secondary, systematized, not elaborated, mood congruent, and associated with feelings of fear. She has acted on this by drinking water, thinking that choking released by drinking water and walking. Pseudo community, she told that there is a pseudo community phenomenon. She told that there is a group of men who have been employed by a boss and trying to kill as a part of unknown mission. Perception is a multimodal in clear conscious and completely organized external subjective space without stimulus, not under control. Auditory hallucinations present throughout the day, more in the morning. Voices of three different people belong to men of a similar age group between 25 to 30 years. Second person hallucinations. Voices speaks directly to her, often giving her commands or making accusatory or derogatory remarks, addressing you as you. These are command or imperative hallucinations. Example, we will kill you. Third person hallucinations, voices speaking about her throughout the day, continuously commenting or discussing about her actions among themselves, referring as her, running commentary type. Example, look, she is studying, we will disturb her. She is writing, now she is getting up and she is looking around. These these are extra campaign hallucinations. The patient can hear the voice close to her ear, though she believes that actual people to be elsewhere in the other localities. Patient has no control over the voice. Insight is absent. Patient's attitude to the hallucination. Patient gets angry and frustrated and puts earplugs and headphones to muffle the voices. Patient has tactile hallucinations where she feels as though inside of her throat is being moved around and twisted. These are visceral hallucinations. This is associated with the pain and difficulty in breathing. This happens more frequently at night, but has been known to happen at other times of the day if she is alone. These occur out of her control and are very frightening for the patient. Patient also has hydric hallucinations, that is uh, presence of fluid, sometimes beer and sometimes water mixed with drugs going through the mouth and throat. Superficial hallucinations. These happen when she is alone and idle and associated with other hallucinations. They are out of control and associated with fear. Visual hallucination, completely organized. She occasionally sees hand-shaped camera. Patient has no control over it, no insight. Patient's attitude to the hallucination is patient gets scared and acts by searching, browsing about it through internet. Gustatory hallucinations. She feels a taste of beer, bitter taste, or drugs diluted with the water. This happens more frequently at night, but has been known to happen at other times of the day if she is alone. These occur out of her control and are very frightening for the patient. Patient started acting out by drinking lots of water and spitting out. Olfactory hallucination. Patient has sensations of smelling of beer and unknown drugs. This happens more frequently at night, but has been known to happen at other times of the day if she is alone. These occur out of control and are frightening for the patient. Patient started acting out by closing her nose. Cognitive functions, attention and concentration. Digit span test has been done. And the patient was able to do forward and backward inference. Attention is aroused and concentration is sustained. Orientation to place, time, place, and date is time, place, and person is present. Orientation is oriented to time, place, and person. Memory, immediate memory, recent and remote memory is intact. Immediate is done by digit forward and backward. Recent memory by 24 hours recall test corroborated with the attender. Remote memory, parents' birthday dates and cousins' names. Intelligence, general information, name of Chief Minister, she told Sidramaya, asked 5 rivers, Ganga, Kaveri, Krishna, Tungabhadra, and Ghattaprabha. And arithmetic, when I gave, she told she will not do it. So, in general information is intact. Coming to abstraction, when I asked about the differences about stone and potato, she told stone you can't eat and potato we can eat. Radio we can hear voice from radio. Whereas cinema, she told it is TV and we can see similarities. Oranges and bananas, she told both have vitamins. Dog and lion, a dog and lion, both the marks, and table and chair, we will use them for study. Interpretation of proverb, she told stitching time saves, I gave her stitching time saves 9. She denied interpreting the proverb. So abstract thinking is intact. Judgment, personal, she wants to pursue a higher education. So personal is intact and social, it is, she is mostly withdrawn, so it is impaired. Test, if there is a, I asked if there is a big fire in the house. She told she will call for help to reduce the damage. If she finds an envelope with a stamp and address, she told she will post it. Hence, test is judgment is intact. But overall, since social judgment is withdrawn and it is impaired, so I infer judgment is impaired. Insight is absent on because she completely denies the means. General physical examination, built and nourishment. She is well built and nourished. No pallor, icterus, sinuses, clubbing, and edema, and no lymphadenopathy. BP is 110 by 70 millimeters of mercury. Pulse rate is 94 beats per minute, and respiratory is 20 cycles per minute. Temperature is afebrile. Weight is 70 kgs and height is 1.65 meters. So BMI is 25.7 kgs per meter square. So patient is patient is overweight. Systemic examination, respiratory system, symmetrically chest movements, bilateral and bilateral normal vesicular blood sounds are heard and no added sounds. Cardiovascular system as well as S2 are heard and no murmurs. Parottomy, no scars, visible veins or sinuses. It is soft, non-tender, no organomegaly or masses. Central nervous system, no focal neurological deficits.
Hello, sir. Can we go with the summary or?
Yeah, you can.
I'm waiting for questions. I'm sure. I mean, there could be many questions. I thought in the MSc
Yes,
as well. Okay. Um, okay. Any questions from the audience so far? Who's there in the? We can see 29 participants. I mean, I'm sure the college, the host college, may not be asking questions. Anybody else? Dr. Kasturi, ma'am, Dr. Anil, and Dr. Lakshmi as well. Or else I will only ask question, I think.
yes.
Doctor, you told that there is poverty of speech is no, poverty of speech is absent, you told, isn't it? Yeah.
Poverty of speech.
Just see, and retardation or something I was just trying to note down. And just see that there in the speech, you mentioned as absent or it is
Poverty of speech is
intact, is there or it's absent?
present, sir. It is present.
You mean to say she is talking about tennis, two types of court, Sania Mirza is a player, she's got silver, she's got gold, Prime Minister gave her awards, it's good for sports. Was not sufficient to say it is just you spoke about that. What is the question you asked about that? You said she likes tennis, you asked about tennis, isn't it?
Yes, sir, as I mentioned in the PPT, like the dots I have mentioned, she was taking the time to tell about.
No, there is increased reaction time. But the reaction time is increased. You mentioned that in your
Yes,
at the beginning of your GABA, I mean, your general appearance and behavior.
yes,
But I was wondering, why did you say it as poverty of speech or poverty of you wanted more number of words, is it?
yes,
So poverty of there is no poverty of content there, according to you.
yes, sir. And she's also talking very slowly, taking time to answer.
Dr. Suresh, I mean, should be like an exam-oriented question to her? Should I ask her about the difference about poverty of content? And can I go ahead like that?
Yes, sir. It can be like exam point of view questions only, sir. So that
Dr. Asha, you're doing, I mean, your presentation is quite good, Kanam. I mean, I'm very happy with the presentations. Just wanted to ask you some clarification on that. Is there a difference between poverty of content and poverty of speech?
Sir?
Is there any difference between poverty of content and poverty of speech? Is there a difference?
Less in content.
Sorry? Now, do you know of any differences between poverty of speech vis-a-vis versus poverty of content of speech? Is there a difference?
Sir, content is like less content she has to speak, and in poverty of speech, she took a lot of time to speak after prompting.
Any better if you want to modify the answer? You can't. Yeah, content. What do you mean by poverty of content? What do you look in a content, Dr. Asha? In somebody's talk in speech, you look at content, isn't it? But what is that content you look at?
So what they're talking, maybe like it's a thought process is what is happening. That will be
What they are
the
talking, you right, but it should have some meaning, isn't it?
yes, sir.
Content is always a meaning,
Yes.
whether it's an abnormal, right? The meaning, right? You wrote that, and I have, of course, you also mentioned about range constricted. What do you mean by that?
Sir, the way she is expressing her emotions, sir, it is she is not fully able to express her what she is feeling. That
She
is
spoke about 10S in the history. She has given history.
yes, sir. But
Uh,
it's always been always by prompting only, and it is she's taking lot of time uh, uh, and also she is more. It took a lot of time for her to tell. It's mostly like a subdued emotions.
was reactivity intact in her? You could make her reactive to your.
Yes, yes, reactivity. I asked her about her any when childhood memories, anything related to sports, because as in his personal history, it is there that she likes sports. So that time when she got about some awards in the sport, then she was happy to talk about.
You also said about controlling actions, right?
Yes.
What is the difference between made act, made volition, and made impulse? Do you know of any differences?
Yes, sir. Made act is starting an act with an influence of an external agent.
Hmm. I believe in your MSc, you said she has some made phenomena, isn't it?
Yes, sir. Made act and made volition.
Which action was controlled by others, by the external agency? Because you mentioned elaborate, systematic. You also used the word systematization quite, and also I think somewhere I written systematized and not elaborated. They can't go
Yes.
in hand. If it is systematized, usually has elaboration. That's
But
where I
based,
was.
sorry to interrupt, sir.
No
Yeah,
problem.
in uh, especially this elaborated comes when she did not elaborated about her section. Am I
Yeah,
audible?
about her inappropriate taste, she was not willing to talk about it. But
Yes,
in
sir.
your MSc, you mentioned somewhere, I was trying to see, notice that you said about systematization, but it is not elaborated. That will not sink usually, Dr. Asha, right? Right. And where else I thought your MSc, can you please come back? MSc, systematize, then next. She denied it. Okay, interpretation of proverb. You said personal judgment is intact. Is it?
Yes, sir.
You want to change it? You want to agree? Personally, she thinks that there are people there are gangsters who are against her, and there is a boss, and the people in the road are against her. It is true that those two people are against her, and people are also behind her, trying to put a chip in her brain in the form of an ant camera. You think it is intact judgment there?
But personally, like I mentioned, like whatever her personal goals, and that is present, but social judgment is withdrawn and
But
suspended.
she is not going to college because of these symptoms, right, doctor? She wanted to finish MCom and she wanted to do something. She's staying in the house, sometimes muttering to self or something like that. I'm trying to ask you.
Okay.
Okay, I leave the questions to other participants as well, please. I think any other participants who are willing to encourage and support Dr. Asha, she's made a very good presentation. Anybody else? Any other PGs
Sir,
to?
Anil sir has asked some question. Extra campaign
Yeah,
hallucinations.
yeah, let me see it. I'm sorry. Let me see it. Anil sir. Uh, Anil sir, let me come down. Let me come. Yeah. Dr. Asha, Dr. Anil Kumar wants to know justify extra campaign hallucinations.
Yeah, he was able to hear voices from other localities.
Able to hear the voices, but it appears to the patient that she is hearing from other localities.
Oh, no, I think there is some, voice issues.
Yes, it is.
Yes, doctor.
Patient is hearing the voices, but she tells that she is hearing from other localities.
Other localities. Okay. You mean to say beyond the distance of the peripheral
Yes,
field,
sir.
isn't it?
Yes, sir.
Yeah, okay. Any other question by the audience? Dr. Kosturi, ma'am? Or shall we go ahead with the another further management plan? Or you have any questions in the MSc, psychopathology? I think we can go ahead, Angara, if there are no further questions. Yeah.
Yes, sir.
Carry on, doctor.
Seconds. Yes. So coming to summary, a 19-year-old female pursuing a bachelor's degree who is unmarried, unemployed, and of middle social economic status came with adequate and reliable information of an illness of gradual onset and continuous course. She complains that she is hearing voices not heard by others, being controlled, and also experiencing multiple instances of twisting and choking sensation in the throat and touching sensations. All these are against her will since 11 months. Since 11 months, she is unable to sleep since the last 10 months with decreased food intake. Parents has noticed that she has been muttering, looks angry when alone since the last 6 months with decreased academic performance, predominantly well-adjusted personality. Physical examination reveals no abnormality. MSc reveals poverty of speech with increased reaction time, low volume, tone and tempo, retardation of thinking. With delusion of reference, persecution, made, act and volition and passivity phenomena, and thought broadcast, along with auditory second person, that is command type, imperative and type, and third person hallucinations, that is running commentary with extra campaign hallucinations, with visual, olfactory, gustatory and tactile hallucinations, which are visceral type, and superficial high-grade type, high-grade type with pseudo community. And the patient was fearful most of the time with sad at times, impaired judgment and absent insight. Diagnostic formulation: 19-year-old female currently studying bachelor's degree in commerce, who is unmarried, unemployed, and of middle socio-economic status, with nil significant past psychiatric, medical, or family history, presented with adequate and reliable information of 11-month illness, gradual onset, and continuous course. Auditory hallucinations with running commentary and command type hallucinations, extra campaign hallucinations with pseudo community, visual, olfactory, gustatory, tactile hallucinations, which are of visceral type and high-grade type hallucinations, characterized by delusion of reference, persecution, made, act and volition with somatic passivity phenomena, are associated with significant bio-socio and occupational dysfunction. No abnormality was found in the physical examination, and MSc concurred with with abnormal psychopathology with poor insight. ICD diagnosis according to the ICD-10 F20 paranoid schizophrenia continuous type with WH access to WHO DDS-40. Obvious dysfunction, deviation from the norm, and interfere with the social adjustment. More severe dysfunction seen on some days. Axis 3 is nil. ICD-11 6820 schizophrenia. First episode currently symptomatic. Management coming to locus, I would like to admit the patient. Indications being severe psychotic symptoms with poor insight, neglect of food intake, and for monitoring purpose. And scales assess the severity. PAN assess. I used PAN assess for assessing the severity. Positive is 31 and negative is 35. General psychopathology score 3 over 129 by 10 with severely ill. Investigation complete blood count, random blood sugar, serum electrolytes, thyroid function test, and ECG. Treatment plan in acute phase, focusing on controlling psychotic symptoms and sleep. So I'll be using a tablet risperidone 2 mg in the night, and tablet clonazepam 0.5 mg in the night, tapering down the dose over 2 weeks, and stop. Injection haloperidol 5 mg deep IM SOS if the patient is aggressive. Prepare for physical restraint if aggression is still not at control. Close and continuous monitoring of the patient. Reassess patient based on symptoms and titrate the dosage to maximum tolerable dose. Immediate non-pharmacological is psychoeducate the patient and attenders about the illness, its nature, course, treatment plan, and importance of compliance. Measure to promote therapeutic alliance and initiation of insight-oriented therapy. In stabilization phase, I'll focus mainly on prevention of relapse and improving functioning. Long term, continue the medication for duration of 2 years minimum from the remission, and continuing the same antipsychotics or switching to be done based on the improvement and side effects. Cognitive behavior therapy to reduce delusions and improve coping skills and behavior. Family interventions to reduce expressed emotion and improve social support to patient parenting, and focus on the academic improvement. Prognosis, good prognostic factors are absent family history, and she's female gender, and yes, according to psychopathology, paranoid subtype, which is intermediate prognosis, no suicide attempt, and cognition is preserved, and it is a first episode. Social, it is good family support. Bagged prognostic factors are early age of onset, insidious onset, long duration of untreated illness. Social, she's still yet studying and unmarried. Overall, it is a good prognosis.
How many more minutes we have, Suresh? I think we are closing towards 1 hour, more than an hour, isn't it?
Sir, another 10, last 10 minutes, sir.
Yeah,
3:15 we can wind up.
Dr. Lakshmi has a question, Dr. Asha. Do you want to give her any insight-oriented therapy on admission, and was he aggressive at any point of time?
No, aggression is not there, sir.
Okay.
But it's I have made a plan based on the SOS basis only. If any aggression, that's why I have given.
And
because
you
we
want to give her insight-oriented therapy when you are going to plan when you are admitting her, isn't it? That's your plan. So you were after admission, do you want to facilitate any insight to the patient?
Yes, sir. When she started taking medications, when the biological like sleep is when she's coming having good sleeps, started to get sleep, then I'll start on her insight oriented therapy, sir.
Overall good prognosis. How will you defend that? Is Dr. Lakshmi's question to you again. I'm reading from the chat box. You've written overall good prognosis, isn't it?
Yes, sir.
How do you want to defend it?
Sir, she is absent because there is no direct family history of schizophrenia or any other psychiatric illnesses, and she is a female, and paranoid schizophrenia. It is a intermediate prognosis, sir, and currently her cognition is preserved, and it is a first episode, and also she has good family support. So as of now, my thing is overall prognosis is good.
I think because of positive question and also positive time, let me give my final impression. Dr. Asha, you present quite well. You are confident. Your flow of words and language is quite very good. In the MSA, I want to give a tip is first mention the psychopathology, then the interpretation last. You don't say delusions of persecution, then elaborate the phenomenology. To
Okay.
describe whatever the patient says, that is your interpretation should be the next. Okay.
Okay, sir.
And
Okay,
yes, otherwise it's quite a clear-cut case. I hope you get such cases in your exams as well. Right? I think closing remarks I leave it to the organizing IPSKC people. Yes, Dr. Suresh.
Yeah, I'm Dr. Suresh here. So this was a wonderful case, especially for a PG learning. And I think for the patient, it may be very, very difficult with so much of psychopathology for the patient. So overall, that this was a very good presentation with so much of active psychopathology. So I would like to congratulate Dr. Asha, Dr. Vidhyavathi Madam, and Dr. Vishnuvardhan sir especially for agreeing to conduct this PG case conference at a single request. So on behalf of IPSKC, I would like to thank the whole Rajarajeshwari Medical College team for their kind support, and I would like to thank Dr. Gururaj sir for agreeing to be the chairperson for this session. With this, I would like to conclude the IPSKC third PG case conference. Thank you, Aura. Thank you, Ananda.
Yeah, bye-bye. Thank you.
Bye.
I think you can wind up. Yeah.
Thank you.